Okay, so we will be starting the last lecture before our tutorial, and this is epidemiology and psychological impact of female pelvic floor disorders and sexual dysfunction. It's just a very simple talk again. Of course. Is it better now? Yeah? Or maybe shall I use that mic? Maybe it will be easier. Yeah? Maybe they can see me.
I think you can be on the podium.
Yeah, that's what I'm thinking.
Deliver from there.
इसको off कर दूं?
You can deliver from there.
Yep. Okay, is it better now? Yeah. So we will start our last talk before our little tutorial about epidemiology. So it has huge impact on quality of life, not only for the patient, but also her family members. A lot of marriages can be broken, and a lot of jobs can be lost, and huge financial impact as well. So it should not be taken lightly, although because there is no life and death, as we were discussing this morning, so these are neglected area for poor countries like ours. Yeah, because obviously if there are limited funds, they will be allocated to cancer or things which are like orthopedic surgery, maybe cardiac surgery, and quality of life issues are neglected. But now we have come to a stage where women's health should get the center stage as well, because we make 50% of population, and these things should be given importance, because suffering, female suffering, is not a suffering of one female. It is actually, it has impact on the whole family, because children look at the face of their mother, and if mother is worried, everybody gets upset. It has effect on the whole society, because women are the cornerstone of our society. So this is the right time that we need to give importance to psychological impact. Oh, something is happening again. So we will discuss very briefly pelvic floor disorders usually faced by, yeah.
मेरे ख्याल से ना इसमें कुछ तुम्हारा बार-बार डिस्कनेक्ट हो जा रहा है। कौन सा केबल?
जो प्रोजेक्टर वाले जो आ रहे हैं
अच्छा। तो ये कौन करेगा सही?
Okay, so we will talk about sexual dysfunction and pelvic floor disorders and the link between them, and prevalence of depression and anxiety in women who have pelvic floor dysfunction. And we will also mention few studies in India done on pelvic floor disorders, and sexual health management versus social stigma, literacy rate, mental health issues. So all of these issues, they affect 50% of the population. And we will mention few studies, I said. So pelvic floor disorders, mostly when we say pelvic floor disorders, mostly we are talking about two things. One is urinary incontinence, and second thing is urogenital prolapse. So they make bulk of the pelvic floor disorders, but there are a lot other problems as well, but they are less common. So we will talk about the frequent problems. So we will talk about stress incontinence, urge incontinence, overflow incontinence, and neurogenic incontinence during the course of this week. But today we are just seeing the effect of these problems on the psychosocial issues. So we will also have a little discussion about fecal incontinence, and it has same impact. So we are talking about pelvic organ prolapse in the course of the next week, the types of prolapse and how do we manage them. Uterine prolapse, and vaginal prolapse, and vault prolapse, and what is the connection of these to mental health. So this is a slide which was shared earlier in the first lecture, the common risk factors for pelvic floor dysfunction. The main thing is chronic constipation, which is extremely common, and we don't recognize this as a disease factor, but actually it affects pelvic floor a lot because of very limited space in the pelvis. So when it is loaded colon, it affects bladder as well as the general pelvic health. So it should not be taken lightly. So chronic constipation must be treated. Second thing is manual labor and heavy lifting. We don't realize whatever we lift, it has effect on the pelvic floor because all the weight goes in the pelvic sling, and with chronic heavy lifting, the pelvic sling gets loose. And the third factor is obesity, that has the same effect on the pelvic floor, and somebody has chronic coughing, that has same effect. And genetics. Can anyone name any condition which can cause pelvic organ prolapse even in nullipara women? Exactly. So two common condition, not common, connective tissue disorders, Marfan syndrome and Ehlers-Danlos syndrome. So I have seen patient like a girl who is like 25 years old, nulliparous, and her uterus is lying outside the body. How disastrous is that? She hasn't even got married or something. Or even if she has just got married, maybe before hymen was holding everything up, and now joint hypermobility and uterus is lying outside. It's an extremely serious condition. So, common condition like bulge in the vagina, giggle incontinence, stress incontinence, urgency incontinence, incontinence during sexual intercourse. So, problem with sexual desire, difficulties in libido, orgasm problems, sexual pain disorders, excitement and arousal difficulties, and all this can be associated, and maybe the main cause is prolapse or bladder problems or incontinence, which results in these types of problems. So, certain studies have shown the link with all these sexual type of problems. We are not going to go into details of this because we are talking more about urogenital physical disorders. But all these studies have shown, all the references there, that it is strongly associated with sexual dysfunction. So again, these studies are talking about stage 3 to 4 prolapse, more likely to cause sexual problems, and the things which we're discussing on the last page. And when we do the surgical treatment, that is the main take-home message, that the sexual disorder can improve. So because the root cause of the problem is in the pelvic floor disorder. Again, the pelvic health is in the center of all these psychological problems, anxiety, depression, body image problems, relationship problems. This is more academic purposes, some of the studies I'll mention here. Emotional strain, effect on the relationship. Financial and career implication, this is mostly in the UK practice, we see this a lot. This is more related to India, stigma and shame. People are not coming forward to discuss these problems, and lack of awareness in patients. Thank you. So access to these facilities, which is pelvic floor health clinic, is obviously a problem here in India. So we are talking about few studies, and there will be references at the end, that rural population and urban population location in India. So 80% is rural, and literacy rate is low in certain population, and parity is quite high parity in most of the women. So all these factors result in pelvic floor dysfunctions. So why women don't seek help? Because of embarrassment, lack of transportation, financial constraints, lack of family support, and they are reluctant to inform their family members, let alone talking to a doctor. And these are various symptoms with prevalence of these problems in various studies. Again, sexual dysfunction, few references. So symptomatic pelvic organ prolapse remains a common condition affecting elderly female, but they don't come forward. Being a hidden disease and due to lack of awareness as well as because of embarrassment, women neglect their symptoms and seek help only when situation worsens. And prolapse affects quality of life involving bladder, bowel, sexual function, and a multidisciplinary team approach. Obviously, this is what we are trying to develop. This is what we are trying to raise awareness. So pelvic floor physiotherapy concept, which we will discuss in conservative management, that how do we develop a team of physiotherapists to develop this holistic approach. So the lesson is the awareness and empowering patient and promoting awareness. If all of you learn that these problems do exist and there is no shame in discussing, and maybe we can start with each other. If all of you have any problem, you can come forward, discuss with each other, and there is no shame and stigma. And if you need any treatment, and that way you can tell your patients as well, when you talk to them about other health problem, maybe you can ask them, do they have any urinary problem? Do they have any fecal incontinence, any problem with sexual dysfunction? So there should be no stigma. This should be the part of the history for any patients you are seeing for any reason. So there are a few references at the end that there is high prevalence of depression and anxiety in women with pelvic floor disorders. So the cost related with pelvic floor dysfunction, medical visits, medication, surgical procedures, and rehabilitation therapies. Indirect costs are because of low productivity, absence from work, reduced caregiver participation, even simple cost of buying the sanitary towels. If somebody has incontinence and they have to buy good quality sanitary towels, it's a huge financial burden. So what we can do, first of all, increasing awareness, and that's the whole idea of doing this workshop. Early intervention, to pick the problem up as soon as possible, and so we can diagnose it and we can treat it. Improved access, develop specialized cares, develop the subspecialty of urogynecology, and then research funding, and then to fight for funding, because here we have to fight for everything, isn't it? To fight for funding, so little research project can be done. For example, comparison of various use of various pessaries to support urogenital prolapse, maybe Gellhorn pessary, shelf pessary, poppy pessary. There are cube pessaries. So all the pessaries I have brought with me, and one of the sessions we will show you all the various pessaries, because things have got quite advanced. So something as simple as a poppy pessary can change a woman's life. Yeah. So we will show you all various types of pessaries, and there are certain pessaries which can be used for stress incontinence. So we'll talk about that as well. Sorry. So applying a life course approach to pelvic floor health, education and information, maximizing opportunities, as this opportunity was seized by Dr. Seema when we met in the UK. Similarly, when you get a chance, seize the opportunity, raise awareness, do something which can improve health of our women, improving capacity in specialist urogyne services, and tackling gynecology waiting list. So these are few references which we use for the studies I mentioned. So any questions? It was just like a brief awareness session about psychological impact and sexual dysfunction correlation with pelvic floor disorder. Any questions at all? I think this is a subject which is not much talked about, but raising awareness is one of the main things. Okay, thank you. That's all for this topic. So the last thing is, I think PopQ. We will talk about PopQ. If nobody has any questions, no? So I know everybody is tired, so we will talk about PopQ. The very last one, PopQ video. before we start the video, I will just say a few things before we start. So what is the need? Anyone knows what is POPQ? Yeah, so pelvic organ prolapse quantification system. So what is the need for that? The problem is urogynecology is a field where a lot of research is going on, and we need a certain system of quantification of our findings which are comparable and which are relatable to each other. For example, if I see a patient and I examine her and I tell you, oh, she has moderate cystocele. Maybe next week you will examine her and you will say, actually, she has got a large cystocele. And somebody else will examine and tell her, you have got a small cystocele. So there is no reference point. So no research can be done because we cannot validate the examination findings. So in order to tackle that problem, a numerical quantification system has been developed, which is called POPQ, Pelvic Organ Quantification System, and it's a numerical system. So in order to develop a numerical system, we have to have a reference point which is fixed and which doesn't change with the prolapse. So there are 2 points there in the vulva which do not change whatever happens. And one is external urethral meatus, which always stays the same place, and the other one is hymenal remnant. So these are the 2 reference points. So we use in the POPQ as station 0. So if there is any finding which I say station 0, this means that part of the vagina or uterus is reaching either to external urethral meatus or hymenal remnant. If with any reading there is a plus point, for example +3, this means it is 3 centimeter outside the hymen. If it is -3, this means it is 3 centimeter inside the hymen. Yeah. So the POPQ is a 9 boxes grid. But the very easy way to understand, because it's very, very confusing, I'll just draw it. And we will see a video which will explain it better.
सबको दिख जाएगा तुम आके
We will see a video in a minute. So all you need to remember, as we were talking about basic and simple things which you remember, all you need to remember, this looks very complex, but in order to simplify it, these 3 readings, just imagine, this is vagina, this is uterus and cervix. So just imagine these 3 readings are anterior vaginal wall. So if you keep that in mind, everything becomes simple. These 3 readings are the middle portion, yeah, which is uterus, cervix and perineum. And these 3 readings is the posterior vaginal wall, which is rectum and rectocele. So that's all I want you to remember for now, because when you see the video, everything will fall into place and you will never forget about POPQ. So these are 9 grids. These above 3, front anterior vaginal wall. This is uterus, cervix and vagina. And this is posterior vaginal wall, pouch of Douglas there. So if you remember that way, it's easier. Another thing to remember, what is point 0? 0 is either hymen or it is external urethral meatus. Anything with a minus reading, with a number with it, for example, -3, this means the reference point we are mentioning is 3 centimeter inside from the hymen. If it is +3, this means it is 3 centimeter or 2 centimeter or 1 centimeter outside the hymen. So in order to simplify, if you see that we don't have much time in clinics, we cannot keep filling all these 9 reference points. So what I'm going to do, I'm going to show you a video and then I'll tell you simplified POPQ, which I have made it myself. So instead of 9 readings, there are only 3 readings. But it gives you equally descriptive mention of the front wall, middle wall and all that. So I'll mention this, but I'll let you watch the video first. So now we can play.
Hello, my name is Fiona Bache. I'm a urogynecologist suspect trainee here at Birmingham Women's Hospital. I'm going to explain the POPQ grading system for pelvic organ prolapse. This stands for Pelvic Organ Prolapse Quantification and is a site-specific tool to describe pelvic organ prolapse. Some centres use it as part of their day-to-day assessment, but it is also very important as a research tool as it's reproducible. There are 9 measurements in total, and these are recorded on a grid. 6 relate to specific points in the vagina, and they are measured with respect to the hymen. If they lie above the hymen, they're given a negative number, and if they are below, they're given a positive number. AA is the point on the anterior vaginal wall that is 3 centimetres proximal to the hymen. So this could be recorded as -3 all the way down to +3. BA is the most distal portion of the remaining upper anterior vaginal wall. So this could be -3, but it also could come all the way out to +5, 6, 7, or even more in extreme cases. AP is the point on the posterior vaginal wall, 3 centimetres proximal to the hymen. Again, this could range from -3 to +3. BP is the most distal portion of the remaining upper posterior vaginal wall and can range from -3 to 6, 7, 8 or more. C is the most distal part of the cervix or vaginal cuff scar if they've had a hysterectomy. So this could have a big range around -10 or could come down to 7, 8 or even more. D is the point in the posterior fornix, and this is often 2 to 3 centimetres above point C, but sometimes the cervix is quite flush with the posterior fornix. This is excluded if they've had a hysterectomy. GH stands for genital hiatus and is measured from the middle of the external urethral meatus to the midline and the posterior hymen. PB is the perineal body and is measured from the posterior portion of the genital hiatus to the middle of the anus. And TVL is the total vaginal length, measured when point C or D are in their normal place. When you examine someone, you can measure each point and record it in a grid, so it's easy for the next person to see what prolapse is present. This is useful for when comparing pre- and post-operatively. So we can have a look at some examples. So here is a cystocele where point AA and BA are both at 0. Here is uterine descent, where the cervix is at -1 and D is at -3. Here is a complete vultiversion, which shows that AA and AP are both at +3, so as distal as they could be. It shows that BA and BP are at +7, which is the same as point C. In this case, there's no uterus, so there's no need to record D. I hope that this has made POPQ a little clearer, and I have more confidence to assess women with prolapse.
So we were talking about simplified version because if you look at it, it can be quite nerve-wracking. So instead of 9 readings, we can just have 3 readings. So we can have BA, C, and BP, and then TVL, 4 readings. So BA is the leading most part of the anterior vaginal wall. For example, if somebody, I would say, +5. So what it will tell me, it's a huge cystocele. Yeah? So I'm using only one landmark, which is the leading part of the anterior vaginal wall, which is BA. For example, I say +5, and along with that, she has procedentia, so whole of the cervix and everything is lying out. For example, I say it is +6, and then BP, she has a rectocele as well, so I would say maybe it is +1. And when I reduce it, the total vaginal length is still 8. So if I have written this in my notes, I know this woman has got a large cystocele, uterus and cervix are almost out, and she has got a small rectocele, but still total vaginal length is 8. So I know there is more readings, for example, genital hiatus, but that doesn't matter, and perineal body, that also doesn't matter when we are describing prolapse. Because we need to know that leading part of the anterior vaginal wall, leading part of the cervix or cuff if they have hysterectomy, and leading part of posterior vaginal wall. So this is a simplified version. So if you see any of my letters for my patient, instead of 9 grid, I only use these 4. So this makes my job quicker, and everybody can understand and relate to it. So after I started using it, all of my colleagues and everybody in our department, everybody uses only description of POPQ, like these 4 points, because this is a simplified version. Because it tells you, for example, if I write BA -3, C -7, BP -3, TVL 8, This is a perfectly normal vagina with no prolapse at all. Everything is where it should be. So that's how it should be. But if it is this is extreme prolapse. If it is a vault prolapse or procedentia, it could be C plus 10. Yeah, if it is procedentia. So something like that. So this is my simplified version. I hope it's a bit easier to understand POPQ now. Okay, any questions now about POPQ or anything else? No? You want to say anything? Sorry? Yeah, so point D. Yeah, it will be point D. And then it is usually not isolated, isn't it? So that will be most like BP, which is the posterior vaginal wall. This is the one which is the leading part of the posterior vaginal wall prolapse. So maybe it will be +5 or something, whatever it is. So if we are talking about BA, that is the lower part of posterior wall, but we are talking about BP, which is the upper part of the posterior, so which can be description of enterocele as well.
So BP is not mentioned here, no?
BA.
Sorry, A.
So A or posterior, yeah. Yeah, so we are only simplified version. We are only talking about the leading most part of, because from practical point of view, it doesn't matter what we are interested, what is the leading part of the most dependent part of the prolapse, because that's what we have to deal with. Yeah? Yeah. 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 So obviously every patient is quite a specialized person, isn't it? So findings will be different for each patient. What here we are trying to do, we are trying to do a generalization for easy understanding. But if you want to do a complex monitoring, you can do all 9 grids if it is a patient which needs description. But in order to make these things simple, because everybody is scared of this, isn't it, POPQ. So what we are trying to do, we are trying to make it simple so everybody can understand. But if you want to do complete 9 grid, obviously you can do that as well.
Anyway, before we take a decision to operate and she's symptomatic and we have to operate, we have to evaluate her completely. And as we are discussing, that enterocele has to be ruled out.
Yeah.
In every case of prolapse.
Exactly.
Before we decide, because the enterocele has to be taken care of.
Because unless there is apical support, prolapse surgery is not successful.
Yeah.
That is a take-home message when we discuss prolapse.
And even if enterocele is not there,
yeah.
Even if it is not there and we are doing a vaginal hysterectomy for prolapse, we do a McCall's cultoplasty in
Exactly.
order to prevent all sacrospinous
Yeah.
fixation. Whatever, like we have to do something so that it does not happen in future. Only
Yeah.
thing different will be if there is enterocele, we'll have to take care of the sac. We have to
Exactly.
dissect the sac and then ligate it and then
Yeah.
do the same thing. Cause for vault prolapse is forgotten enterocele. Yeah, missed it.
Exactly.
Missed enterocele.
Yeah.
Yeah.
Yeah. Yeah. So the recurrence of anterior vaginal wall prolapse, the recurrence rate is 33%. The reason is because we miss the apical support. So we have to do something at the apex, otherwise prolapse surgery will never be successful, especially with large prolapses and the one with the apical support. Okay, thank you. Thank you very much.
Anything for different laxity of vaginal wall?
So that is called site-specific prolapse repair. Because it depends, most of the reason of prolapse is usually childbirth injuries. So if it is odd position of the baby's head, or if the forearm is coming or elbow is coming, and it has destroyed a specific part, or if you have used forceps and the blade has destroyed a specific part, rest of the part is intact. So we need to do thorough examination in lithotomy and sideways to identify that part. And then we can open that area and do site-specific prolapse repair. Not necessarily it has to be midline fascial plication as we do. It has to be site specific. So again, that will depend on the patient's.
Sometimes when we are doing a punch rectum examination, we see the lateral vaginal walls is very less where they are coming.
Yeah. So in that case, if the total vaginal length is adequate, which is like 8 centimeter or 9 centimeter, if it is not a short scarred vagina, in such cases, sacrospinous fixation